Good morning, good evening, depending on where you are in the world. As you might notice, I've got a mask and some headphones on. I'm actually sitting in the airport in Mobile. My flight leaves in about an hour, so I'm likely to have to drop a little bit early. We've got an interesting show today, though. We're going to start off with a brief discussion out of the Prevention Myths book. And it has to do with Framingham Risk Estimator. You'd probably have not noticed that. Your doctor's probably not mentioned it. But he or she is doing the Framingham Risk Estimation when you walk in the door, and he or she starts asking about, okay, well, how old are you? They think about your gender, they look at your family history, they look at your cholesterol level, and then they start thinking about, okay, do you need should we do a stress test? Should we put you on Lipitor? You know, some of the standard things that docs think about in terms of cardiovascular prevention. And one of the things we'll talk about is that the Framingham Risk Estimator is flawed. This is not something I made up. This is something that, if you go back even into New York Times and several other lay newspapers, they cover some of the articles where, like Paul Ridker, folks at Harvard, folks at Mayo, a lot of folks at Johns Hopkins talk about challenges with the Framingham Risk Estimator. But then we've got a special guest today, and she's going to talk about, you know what, does this, some of this risk estimator, some of these more detailed things about cardiovascular inflammation versus LDL, how much do they really matter? And LaTanja is a great NP that's working with us in Mobile. She's at the clinic with James, and she's going to come in and talk a little bit about what she sees in terms of the population that she's worked with. She's worked in this specific space, Medicare Advantage and prevention, for quite a few years and has a lot of interesting perspective. Before we get started, just the routine comments about our what's available to you. This channel is all about helping folks understand that it's really prediabetes, unrecognized diabetes, sugar problems that drives the majority of these issues. They drive cardiovascular inflammation, and your typical doc does not know about that stuff. So we can't provide care for everybody, but we can make that information available. So that's how we do it. We've got core content for this channel. We've got it in webinar form. We've got it in course form. And we look at, for example, the core issues. How do you estimate plaque? That's one of the things we'll be talking about today. There are major problems in how doctors estimate plaque. Cardiovascular inflammation, as we discussed, that's probably, well, there's plenty of evidence. That's a bigger driver than actually what most docs look for in terms of heart attack and stroke risk. Inflammation. Now, most docs don't even really understand what that means, but that's not, we're not going to talk about that today, but you can, with just an hour or two, know probably more than your doc about that specific issue. And then we've got some clear information about the number one driver. Drives at least 75, probably 85% of this problem, and that is unrecognized insulin resistance, prediabetes and diabetes. Just one other thing before we get there. Again, a lot of the content for today's discussion, the slide discussion, the presentation part before James and LaTanja start, comes right out of the Prevention Myths book. So we'll cover a lot of this stuff really quickly. If you have questions on it, we get into some pretty deep detail on this issue, as well as many others on how to estimate plaque. And yep, a stress test is not a great way to do that. So let's get started with it. The Framingham Risk Estimator's really not a screen. It doesn't measure plaque. It's a guess. And, you know, a lot of folks would not be happy to hear me say it's not a good guess either. But like I said, I am not the only guy saying that. Just go look at the science. It's a predictive equation. It's developed from the Framingham Heart Study, which started back in the 50s. This study's been renewed. It's now gone through 5 cohorts, I think. If you're not clear on what a cohort is, it's just 5 generations of folks being studied. It includes medical history, demographics, smoking history, things like that. It also even includes a tissue bank, a serum bank, most of all. So with a serum bank, you can go back and say, look, we have questions, for example, about some of the more common ones were what level of cholesterol somebody had when they were 10 years younger. If you can convince the group that your study's worth taking a look at, they will let you go back and take a look at some of that old serum to see what that level was. So back to the score itself, it translates into a 10-year hazard risk ratio. It estimates your risk of having a heart attack or stroke. Now, these risk factors are important. They're not unimportant. But the dependence on a scoring tool leads to misdiagnoses, opportunities for treatment, and some issues. Here's an example. Susan's 62 years old. She was taking 20 milligrams daily of Lipitor. Her doc put her on that simply because her LDL was 105. But once you actually start measuring her plaque, she didn't have any. So she talked about her family history. She talked a little bit more with her PCP, and she talked with me. And after some discussions about her true risk, she decided, you know, I don't think I want to take those right now. Now, again, a lot of docs would say that's crazy. Anybody with an LDL of 105 should be on a statin. Yes, that's a very common standard that you'll hear, but again, there's new evidence coming out. There was a study recently that showed there's just not significant risk if you have a negative calcium score. So that brings up the point that maybe we should be doing some things like calcium scores, CIMTs, a little bit more measurement of the actual amount of plaque. As we said, Framingham started many generations back. It's a town in the south of Boston. Congress originally commissioned the study for 20 years. At the end of 20 years, the docs, the epidemiologists running it said, you know what, we need to close this out. Congress said, nope, we're not going to do that. And at this point, I think most of us are happy that they didn't. Even though you've got some challenges with Framingham, it has been a massive boon and improvement for us to understand exactly what sort of things cause heart attack risk. Now, for example, dietary issues, you know, all the lifestyle issues that we talk about and the importance, that most of that clearly came originally out of Framingham and has continued to be demonstrated elsewhere. Now so we've talked about places where you may have a problem. And so let's just look at the data from one of the studies that these guys from Hopkins and Mayo and Harvard are mentioning when they're talking about actual risk versus true risk. Over on the right-hand side, this is a study looking at actual risk versus Framingham estimated risk. And as you can see, these lighter bars were the Framingham estimate. The darker bars were the actual risk that they saw. And yes, the ones where you get this huge this difference is women. One study showed that among Japanese American and Hispanic men and Native American women, the Framingham risk factors systematically overestimated the risk. The most recent Framingham calculator often doubles the risk, especially in women. Yes, like I said, you don't have to be scrubbing through academic medical studies. New York Times has already covered this. And so what happens then is a lot of people get put on statins that maybe should not have been put on statins. So one of the questions that comes out of this is, well, why is Framingham a problem? Or what causes the problems of Framingham? The bottom line is the guidelines go back to 2013, or the data that's used in the guidelines. So the obvious question is, well, obviously we've had some significant improvement in risk. Why don't we use newer data? That 2013 and prior data is the data that's available, and it's the most recent data that's available. It takes a long time for, to quote my friend James, the sausage to be made to take the studies, get them completed, get them peer reviewed, then get them into something like a Framingham risk calculator. So then the next question is, well, if the 2013 numbers were bad, why don't we go back and use prior numbers? Well, the prior numbers are worse. So again, we just need to, there's no suggestion. It would be crazy to throw Framingham out the door. Framingham is a critical tool, but you just need to know what you're dealing with. And usually your doc's not going to know this kind of stuff. I've already covered this. This is some of the research that the articles that came from. So, James, are you and LaTanja available?
Well, LaTanja is not available yet. She's still seeing a patient, but there are a couple of things that while we're waiting on them, if you've got a few minutes before your flight, some interview questions I'd like to follow up for our audience with you and some comments to make.
Great.
Great. Number one, I'd like to make a congratulations to you, Dr. Brewer. The audience may not realize, but this week we passed 100,000 subscribers to the PrevMed channel, and that's a congratulations to you and the hard work.
Thank you.
And also, I might say that behind the scenes, people don't know that you have a team of people, Gilbert and Aspen and Carolina, and I'm missing people, and I apologize. Michelle, Janice.
It's a big team. Haywood, Carolina, Ceci, Jesus, Alfredo.
Right. And all of them played an important role. And so congratulations for 100,000. Now you now are an influencer, and some of the ladies that work here in the clinic that we've launched were joking about calling you now, getting you a TikTok show so you can be a true social media influencer. So, there's you, there's Kim Kardashian, Miley Cyrus. So it's good to be an influencer. And LaTanja is joining us. I'll let her sit down and get situated where we can see her. LaTanja, we need to get you in the scene much more than me in the scene. So
there we go. One other thing. Hi. One other thing before we also didn't mention Sam and Aspen.
Yes.
Two key members of that team. So thank you guys.
The guys did a great job of helping us build and grow that, helping you build and grow it, but you've done a great job as well on this channel. And our subscribers, the people who are on this show, I want to thank them too, because they make a part of consistently being on the show and recommending people and supporting it. It makes a big difference in people's lives, and it takes a village, and everyone's involved in that. So thank you guys very much. Let me introduce LaTanja Batain. LaTanja Batain is joining us, and she is a nurse practitioner here in the Mobile, South Alabama, Lower Alabama area. Most important thing to know about LaTanja that I like most about her is Roll Tide.
Roll Tide.
season ticket holder, multi-year, and she's a winner. She likes winners, and so somebody for me to talk to in the clinic about dominating football.
I hope we don't have any Auburn fans.
No, they're not smart enough to be on to work YouTube. Yeah, they couldn't figure that out. They're working on their coloring books right now, so it's no. And you can't do anything with those people anyway. So, and if we did a channel on mental health issues, we could probably get more, Auburn fans.
Painful. So I will say this: I may have to drop off in a few minutes, LaTanja. Thank you so much for joining James. And I just wanted to give you 30 seconds on what we're talking about. We're talking about how the Framingham risk calculator, everybody uses that, whether they're thinking of it or not. And quite often they don't even use that. They just look at a cholesterol number and say, okay, statin or no statin. The reality is the Framingham risk calculator is a wonderful tool. I would not suggest throwing it away, but there's clearly a lot of evidence which indicates the Framingham risk, especially in women, is often twice their real risk. Now, all of that gets a little bit academic, like you and I were talking about yesterday. When you start dealing with the patient care challenges that you've been dealing with for the past decade. So I just wanted to tee that up for you, and I'll back away, James, and let you guys.
And I'll ask you one more question, Dr. Brewer, about that, and then we want to talk about, I want to interview LaTanja about practical medication adherence and people on statins and other drugs. But are you aware of the practice in the VA, for instance, to just across the board subscribe statins to all patients at a high dose? You have a comment on that as kind of a preventive, like you and I have discussed before on the show, metformin, which there's a question about metformin, about being, kind of a panacea. But the VA evidently considers a statin a panacea, and they write a high dose of it to practically all patients. So do you have a comment on that?
I do. Thanks for asking. So you see that in so many places. For example, even in HEDIS, and I know LaTanja's already reviewed some of our HEDIS activities. One of the key things that HEDIS requires is that you look for anybody that has diabetes and make sure that they're on a statin. Now, from my perspective, I do think it really starts to get to splitting hairs to complain about that one. Because as we know, you're not going to get to a diagnosis of full-blown diabetes in this medical world without having some significant diabetes problems. The vast majority of diabetes still being missed. So I don't think that's that much of a problem. I worry about a standard like you just mentioned, where people say, you know what, just put everybody on a high dose statin. Because the other thing we're talking about is, yes, LDL matters, but compared to diabetes, it's not nearly as big of an issue. So it's sort of like the problem with the Framingham, where we do sling around a lot of statins, and again, that's a challenge dealing with that issue.
Well, we probably would get a different opinion if we could get some of these statin companies to, pay us like they do some docs, large sums of money. But so we haven't sold our souls out yet, so we kind of have a different approach and view of it. Let me add one more thing as well. As we described, the audience has kept up in my absence the last few months. We came down. We have a clinic now that's open. We're in clinic. Today is one of the very early days in Foley, Alabama. We have one opening in Spanish Fort, one opening in Fairhope, and then in Mobile. And so for our audience that listens, we actually have decided and started opening these prevention clinics that down here, they're called Jubilee Primary Care. If anyone has family in these two counties that are Medicare age population, then we are taking new patients. It's a fast growing area, and there is a shortage of primary care physicians. And so we practically are open clinics. LaTanja is one of those nurse practitioners that's working with the physicians that we've hired here as well. And one of the reasons we brought LaTanja on is she had this deep experience in working in the community in prevention already and doing homebound. So a little bit of her background, LaTanja did do homebound work with patients in the community, as well as working in the clinics themselves, as well as working with the health department. So she got this vast experience of years, although she's very young. Still, one of those Doogie Howser, started growing young kind of people, like Dr. Brewer. And so some of the questions we want to cover today was practical. So tell us, LaTanja, from your experience, what were some of the reasons? Because there are times when you do want a patient on a statin, and statins are some of the drugs that we've seen in past history that are more difficult to get people to be adherent to. So tell me some of your past experience on why do you think patients practically find it difficult to, and why do we as providers find it difficult to keep people adherent to their statins and diabetes and other chronic disease medications?
Patients would tell me sometimes in the clinic, or when I would go out and see them about medication adherence, one of the complaints that you would hear sometimes are the side effects. Also remembering to take their actual medication, or just saying some patients, the costs may interfere or affect them taking their medications as required on a daily dose. One thing as a provider you must do is explain to patients some of the actual side effects that you may encounter, a patient may encounter when taking their medications as prescribed. If you talk to them and explain to them the actual side effects that they may encounter, then they are more, I think they are more capable of taking their medications as they should. When the providers don't take that minute to explain the benefits, also the side effects, that will cause patients not to adhere. A lot of my male customers, patients, when I would talk to them about why they're not taking their medications, the diabetic medications, their blood pressure medications, the cholesterol, they talked about the impotence, and then you had to explain to them, there's different things that they could actually do in taking their medications. That's something they need to bring up with their actual provider, whether it's the change of a medication or, it's other measures that you can actually take, but it's really important to take the medication as prescribed.
Yeah, that's a great point. You gave us an example of a side effect. With statins, what do you typically have heard and seen are some of the side effects? Our audience, probably a real sophisticated audience, but some of these statins, what do you see are the more common side effects of taking a high dose statin or a low dose statin for that matter? Well, but particularly the high dose.
The high dose statin, my number one complaint was the male impotence there. It's like, that would be for my male patients.
That's a very serious issue, Dr.
Yes, that's so serious there. And that would be one of the things that I would hear from a lot.
Right. What about muscle pain? Are they affiliated with
I
that?
had
a lot of that.
Not a lot. Right. Because with the muscle pains, we also, there's measures, try to exercise, increase your activities. Also, you had your patients that was also taking a low dose aspirin, so they didn't complain about it too much.
But impotence is probably the most with high dose statins.
Yes, sir.
And, now, did you find that you could help fix that with also prescribing something like a Cialis or some other, or did the aspirin help with that as well? Because aspirin has similar effect.
Yes.
So you would give hope, kind of the point
yes.
I'm making, that
there are measures that we would take to actually help with that. And you have to tell them the importance of taking the statin there into them stopping the statin, because like we tell them, okay, you stop the statin, your cholesterol, you're looking at the levels going up. So that's going to cause the same problem. So the importance of taking it, you have to stress it there, and listening to your patient and being able, once they verbalize a concern, to me, if I address that concern, the compliance is much better.
You make an interesting point about addressing that concern. So there's an underlying experience from just population health. My perspective is getting people to actually talk to their provider. So there's a reluctance often to reach out to know who to talk to, because they feel like patients could comment below some of it. Is, well, who do I call? Practically, who do I call? Who do I share that with? How often should I call? Should I even share it, or should I just stop? So we know they just stop. So what would you, if you had a patient and you were talking to me and I quit taking it because of impotence. Mm-hmm. I have 6 kids. I need to quit taking it. Because, there's a whole nother conversation that we could have about that. But as a patient, who would I call? And what, are you bothered by being called? Dr. Brewer, are you bothered? Because I think patients are afraid of that conversation. So tell us some about what you would recommend people do.
I try to make my patients feel as comfortable as possible. That's one of the things you should always do. Just like going in, I feel like everybody needs to feel like there's some type of personalization. I would always make these notes in the top of their chart, and before they come in, it's something I remembered about you. Right. When I went in to talk with you, hey, how are you doing? How was that trip to California to go see your daughter? And right. They felt like there's a personalization. Then also being able to communicate and talk. At the health department, that was one of the things. I met my quota each quarter, and we saw patients every 15 minutes. And to me, when your patients feel like they can communicate with you, I'm just not a patient. I'm not in and out. Right. Even though we saw them every 15 minutes, that's how my schedule was set up. When I walked in, they felt like, oh, she remembered me. She know me. I'm just not throwing in and out. So when there's a communication, they were able to speak with you. And I had a very high male population also. And they could open up and discuss things with you. If there's a concern, I feel like the more I was open as far as discussions with a patient in clinic, then to me, they're more compliant with their care.
You're okay. Call the clinic, ask the nurse to let you talk to the nurse practitioner or the physician, mm-hmm. because you're having an adverse reaction. They, to a patient, we would say, in the new world of fee for value, which is the world that it is changing, it's critical that people are adherent to medication. So we are setting up systems, Dr. Brewer, I'd speak to the patients that says there is someone there that's really concerned about that patient taking that medication, taking mm-hmm. that statin, taking that metformin. So there should be an open audience. If you don't get the kind of response that you should get, which is a callback in under 24 hours, mm-hmm. and a follow-up question. They may have follow-up questions about other medications you're taking. I mean, if you don't get that response, then you're not working with a clinic that's mindful of what they should be doing. So there may be reluctance on the caller's part, but there are now systems where the physician, the nurse practitioner, the clinic wants to hear from you why that you're having problems with medication, mm-hmm. and they want to fix that because there are benefits that come to us for having fixed those problems.
And usually what may come as a problem for one patient may be able to express that concern. You may find that you're having more patients with that same concern, so you know how to address it. With the Athena system that we were using, our patients were able to send in their questions there. And when they're able to send in their questions, we had a little mailbox. I address your questions usually within the next an hour. You know, between patients, I always respond. That was one thing I did. And on my lunch, I always brought my lunch, and I was able to sit and respond. If I had the question prior to lunch, it was answered, you know, during lunchtime, and if I needed to call you back. That's why I feel like there should be an ability where the provider is able to speak with the patient. My schedule stayed busy, very hectic, and it was just making it time. Right. And my patients did very well as far as medication compliance there. Excellent. And one-on-one, we had the nutritionist in the clinic, making sure that they get with the nutritionist to talk with them on diet. I think that was the biggest concern that we were having also, besides the compliance, is the diet. When you're in a underserved community and patients are used to eating, you know, unhealthy diet. This is the South. You know, everything is fried. All the seafood is full of garlic butter. Now you're just meddling now. Stop with this running down our food. So my Aunt Martha don't change the cooking at the family events, Martha. Fine, I'll take my Lipitor. Thank you very much. But that was one of the things you would actually have to see, the non-compliance, not only with the medication, but with the diet also. It's a good transition. If you look at the comments, Dr. Brewer, there's some comments around this. So for instance, my Aunt Martha, who's listening, asked what percentage of people with high LDL triglycerides choose lifestyle changes rather than taking medication. Earlier, you're going to see some other people. Mega How-To Man says, hey, my cholesterol is 250, and he comments about getting a calcium score done. So within our comments, Hal Slintz Whalen says, I'm a statin dropout, now focusing on with flush niacin to raise my HDL and fight my chronic inflammation. So a lot of the comments here, I'm jumping ahead for it on those, on Dr. Brewer, are what lifestyle? So comment real quickly about, can you really move off statins if you change that lifestyle? Is that a practical goal? Do you feel like that can be done? How long does it take? If someone really becomes aggressive, assuming they don't have some type of hereditary issues, such, you know, hypercholesteremia and so forth. Do you want to comment on that, Dr. Brewer?
Yes, I do. Thank you, James. Mega How-To Man said, my cholesterol is 250. The real question regarding FH is, or familial hypercholesterolemia, is how high is your LDL? You know, James, for those of you who don't know or don't remember, James started and ran a human genetics lab. So he knows this space very well. He actually was one of the first guys to make tests like haptoglobin and FH available easily on a retail, you know, to those of us in the public. Now, the real question again is LDL. If your LDL is 180 or above, you probably have FH, familial hypercholesterolemia. The vast majority of doctors are not aware of that. They just look at it and say, wow, your cholesterol's high. Now, here's the other thing. There are, you know, like everything else, there are websites for people that have FH. And you'll see people say, oh, my goodness, I've got FH, or if you've got FH, your risk is just out the roof. Not so much. You know, James again, saw that alert, and I appreciate you getting my input. I've got dozens and dozens of patients with FH. Now, the risk is not nearly so high as you might think. Your typical FH patient, now there's heterozygous and homozygous. Homozygous means you got an FH gene from your mom and an FH gene from your dad. And those folks tend to have an LDL 300 and more. Totally different ball game, and those folks can end up having heart attacks in their 20s, even their teens. So the people that you hear on the internet that say cholesterol doesn't matter at all, that's not true. But also, you know, it's like so many of the things we talk about, you can go too far on one end or another. You can give way too much statin way too quickly. You can say LDL it is a good thing. You know, the reality is there are times for statins. More often than not, it's a lower dose, not these huge doses that James mentioned earlier. With FH, clearly the homozygous FH patient experience makes it very clear LDL does matter. But does it matter as much as we think it does? Probably not. And again, so that's the thing, mega how-to man. Take a look at your LDL levels. One other quick place, and I'll be quiet, James, and hand it back to you and LaTanja. People talk about lean mass hyperresponders, and there's a fellow named Dave Casson, can't remember his last name right now. He's got a website called the Cholesterol Code, and he talks about a thing called lean mass hyperresponders. These are people who go on a low carb diet and their LDL shoots way up. Now, again, for a long time, people thought that was just me and some other and Dave and some other crazy internet people making stuff up or talking about stuff that's not really that practical. That's no longer the case. That you're now seeing Harvard, some of the other well-respected medical institutions talking about how going on a keto or low-carb diet, many of us will actually have a significant increase in our LDL. Also, the question then becomes, well, if high LDL is a big problem for everybody else, doesn't that mean that's a huge problem for them? I can't tell you the number of patients I've had come to me, and their cardiologist or their internist scared them off of a low carb diet because that LDL started climbing. And the reality is that none of us that I've seen yet would say, yeah, you get a lot of risk from that lean mass hyperresponder thing.
I might recommend that our listeners go back into the library of content and YouTube and look at some of your previous videos and look not only at their LDL levels, but look at some of the work you've done on niacin and fractionated lipids, particle sizes, and oxidation of those LDLs, because you've got some great content out there to look at that says it's just simply not a number, but what is that number doing? Are you having a lot of inflammation and oxidation? What's the particle size? What's your LP little a? So they can go look at some of those videos. You have those. They can Google them, YouTube them, and watch that and learn a lot. and taking control of their own care and asking the kind of lab tests that they want to look at with their provider and educate the provider if they're not familiar with those issues that you've raised in other content. I know I'm half-faced here in order to get us both here.
That's okay. Real quick statement. Martin Kleingold did a fact check for us. It's Dave Feldman.
Right.
And his website's called the Cholesterol Code. The only place where I would disagree with Dave is he says that FH and lean mass hyperresponder are two totally different things. He doesn't really understand FH. I mean, James can tell you there's 2,000 different genetic variations that lead to that. And there's significant overlap between FH and lean mass hyperresponders. Thank you, James. I'll be quiet.
No, that's great. Well, I want to thank LaTanja. I think we're done. We have patients to get back to because we are excited about what we're doing and getting what you and I and we've done for years in theory, we're putting in practice in this first market down in Alabama. And so we'll hand it back to you, LaTanja. Thank you so much for giving us some of your thoughts and insights. And I know you've got to jump on a plane and our time's about up, Dr. Brewer. So let me hand it back to you and thank the audience again today for their participation.
Thank you.
Thank you, LaTanja.
Thank you, LaTanja. I do have a couple more minutes. We've had some great comments. I'll just go through and make sure that we've covered as many of them as we can.
Well, we're gonna bounce off and go see this patient. And thank you very much.
Very good.
Talk to you soon.
Thank you so much, LaTanja, for bringing a little bit of reality to what we talk about.
Thank you.
Thank you. Bye-bye.
Bye-bye. So, Bart, good morning. Thank you for joining us. E.T., thank you for joining us. Martha Wright, good morning. Thanks for joining. Yes, we're the team. A lot of people heard that description of the team and the COVID troubles last a few weeks ago. Everybody on the team is healthy and doing well now. Some of them still have a little bit of cough and things like that, but they made it through. Demographically, the guys that had the worst time were middle-aged men, which we've seen before with that virus. How do I get metformin? You can call Michelle. We have a metformin program, Mega How To, and you can call Michelle at 859-721-1414. That's 859-721-1414. Yes, calcium score. Most insurance companies are still not paying for it. Some of them are starting to, because it's starting to make it finally into the standards. We're having a series of meetings this month with a couple of insurance companies about CIMT, and they're not quite ready for that yet. And I've had those discussions with insurance companies for several years. I agree with Bart. These to pay out of pocket for these tests, well worth it, very worth it. Thanks, Aunt Martha, for the yoo-hoo on the numbers. And thank you, Bart. We're glad you appreciated the content. So the new doctor will be reading the book, whether he likes it or not. Thank you so much. Bart has shared with us that he's been doing a lot of sharing, reading and sharing of the book. Mega How To Man, cholesterol is 250. We talked about that. Calcium score will give you a lot more information than a net cholesterol. You betcha. I agree with you, Bart. Yeah, that's a frustrating thing to have to resort to. They talked about giving Cialis for ED associated and associating that ED with statins. Well, that's a deeper conversation. As a couple of points. The first one is most of us, most of my patients, myself included, want to delay going on statins whenever it's time to do that. And many of us will. Myself, I delayed it for a couple of years because you want to try to manage it with lifestyle. But there's some things that we miscalculate. We don't think about actually documenting plaque. We don't think about low dose versus high dose statins. We don't think about making the lifestyle changes we need to make. We tend to be too focused on drugs in this culture. What percentage of people with, oh, we talked about that. Thank you. I'm a statin dropout, now focusing on high flush niacin. Yes, we've got several folks who do that. Thank you, David. Yes, as Kirk said, I'm one of our FH patients. Mezzanine, good morning. Dave Feldman, thank you, Martin. Appreciate that. Why would a person prefer Medicare Advantage? There's a whole bunch of reasons. One of the key issues is you can get very high level, very focused preventive care, and especially for folks that tend to not be able to afford spending, going to a doctor where they spend half an hour. You can get much more of that in a Medicare Advantage world. It tends to be an HMO. The vast majority of it is an HMO world. So a lot of folks say, oh, this is the land of the free. I don't want to have any selection on my doc. Places like Alabama, you tend to not have that gatekeeper mechanism anyway. So Lawnmower Man, quintuple bypass, wanted to say thank you so much for sharing your knowledge and wisdom with us today. Thank you so much, quintuple. House lint, the battle is not with LDL, but inflammation. Please stress flush niacin. Yes, we've got a whole series of videos on niacin. I'm going to have to run quickly through, so I won't be able to spend much more time on that. Robert Burns, $9.99 super chat. General MD able to read a CIMT scan? Nope. It's read by a radiologist that knows how to read those, just like X-rays are in other studies. I found a place that does the scan but doesn't interpret the results. Robert, what I would recommend is that you call Michelle at 859-721-1414, and she can hook you up with a group that does both. And there's a significant challenge with garbage in, garbage out. So the vast majority of CIMTs that people bring to me when they come to me are garbage in and garbage out. So there's a huge quality challenge there. Michelle can help you get hooked up with some providers around the U.S., assuming that you're in the U.S. In our worth the expense for the average wage earner. I think you might be. Are you talking about nicotinamide riboside? If so, I've tried it a few times. I don't really think that the data is that conclusive yet for nicotinamide riboside. It's supposed to be a no-flush niacin equivalent. Thank you so much. We have got to go to a flight. We appreciate your interest as usual.